Yeah, thanks for the opportunity to come and talk today. My name is Dr. Hirten. I'm one of, as I mentioned, one of the GI attendings at Mount Sinai, and one of the IBD doctors here. At Mount Sinai, it's interesting and a little bit unique in that we have our GI clinic and our GI practices is at one spot, and then we have a fully dedicated IBD center also, which is essentially a floor of one of the buildings. And it really offers like a medical home model for the care of inflammatory bowel disease. And we really have this rich history of IBD at Mount Sinai. Dr. Crohn was a gastroenterologist here and first describing Crohn's disease in the 1930s. And really since then, we have one of the largest patient populations of inflammatory bowel disease patients in the world, seeing roughly around 1,400 people a year, individual people a year with inflammatory bowel disease. So, if anyone on the call is interested in GI or especially in IBD, definitely feel free to reach out. And if you wanted to come rotate us time at our IBD center, it's a really nice opportunity to see a lot of inflammatory bowel disease in one setting and sort of how it's approached. The overviews, this kind of goes over a lot of the general things that we'll be covering today over the next 40 or 45 minutes. So some of the characteristics and treatments of IBD, understanding maybe the etiologies of it, what are the signs and symptoms of Crohn's and ulcerative colitis, how do we approach some of the health maintenance that's relating to IBD, and then a little bit of the inpatient management of inflammatory bowel disease. And really the goal at the end of this is so that hopefully everyone has a pretty good broad sense of what IBD is, what it looks like, what the differences in the disease type are, and then how we sort of approach it in a general sense, which I think is really important for those going into general internal medicine. But for anybody that's really interested in GI or further learning more about it, we'd be happy, again, like I mentioned, to have anyone over at our center to spend time rotating. So I designed this to be kind of interactive. So I don't know how these are normally. So I was going to go through cases and then we were going to talk about things. And I was hoping if people would contribute, that would be great to answer some of the questions as well. I don't know how you normally structure your academic half days, but if that's okay. So I'll start here. And if people don't want to chime in, I could always, of course, go through it like a PowerPoint and go through some of the points. So let's just pretend this is a hypothetical situation that you're seeing in your clinic. So you're an internist, you're in the office, and you're seeing a patient for the first time. In this case, Rachel, she's a 24-year-old woman. You're seeing for the first time in your clinic, and she tells you she was just diagnosed with ulcerative colitis 2 weeks ago while she was hospitalized, and she's confused about her diagnosis. She isn't sure what ulcerative colitis is, how it differs from Crohn's disease, or how this differs from inflammatory bowel disease, which she's been reading on the internet. And she asks you, can you really help describe to me, what is this? Because it wasn't clear when I was in the hospital. So it seems like a really high level, like sort of straightforward question, but it's important because we're always approached by our patients, like when we see them in our IBD center, and people don't have always a good understanding of what is IBD, what's Crohn's and what's ulcerative colitis. So I don't know if maybe someone would want to kind of take a stab to start with and say, like, how would you describe to Rachel sort of what inflammatory bowel disease is, kind of in a very general sense? Anybody?
So it's kind of, we should not be using the word inflammation, but I guess it's really, it's useful to specify that this is not an infectious process. It's just an inflammation because of intrinsic, signals in your body that is causing the inflammation that is attacking your own body. But I don't know how to describe it without using that word. I think it's easier when you ask the difference between Crohn's and UC, because you can specify, well, the Crohn's affect a specific area of the GI tract. UC is more delineated to the colon, and like the distribution of the lesions. But the first question is kind of difficult to explain, honestly.
Yeah, but you hit on this in an important way. So it's not an infection, and that's very, very important to kind of delineate to people right away. Yeah, this is not an infection. And so IBD, I always describe when I'm talking to my patients first, you say, all right, inflammatory bowel disease is sort of this encompassing term that includes Crohn's disease and ulcerative colitis. It's sort of like a much broader terminology. And what it is it's inflammation that's occurring in your gastrointestinal tract. And we'll hit on what kind of causes it. But you're right, not infections or things like that. And people always ask, like, well, what is inflammation? Like, what does that mean? Which is hard to describe. Like, what's inflammation when you don't use kind of more technical terms? But I describe it as what it ultimately will mean then is you have redness, which is like irritation, like if you irritate your skin of the on your hand, for example, it'll turn red. That's happening in your intestinal tract. You're getting ulcers, which are like these little cuts that can form as well, that can bleed. And through this damage that's happening in your GI tract can cause a lot of symptoms, which we'll also talk about. So it's sort of like this very basic sense of what is this kind of inflammation in the GI tract, and that's IBD. And then you hit on this point that we break it down to Crohn's and ulcerative colitis, and this is where really we kind of get to that crux of the differences. And maybe let's start with ulcerative colitis. So where does ulcerative colitis affect in your intestinal tract? Anyone able to sort of maybe say where we would expect to see this happening?
So it'd be mostly starting from like the colon?
In the colon, yep, exactly. So it has to be in the colon. And where in the colon in particular?
Rectum.
The rectum. So this is key. You have to have rectal inflammation in ulcerative colitis. And what's characteristic of that inflammation in ulcerative colitis that at least has to be in the rectum? What does it have to sort of like look like or appear like?
Continuous.
Continuous, perfect. So it's continuous circumferential inflammation that has to involve your rectum. And then from there, any degree upward in the colon, it can extend. So it can just be in the rectum, ulcerative proctitis. It could involve 20 centimeters, 30 centimeters, any degree upward. Beyond the rectum, beyond really involving that 10 or 15 centimeters of the rectum, it's then called ulcerative colitis as opposed to ulcerative proctitis. And you can very clearly tell the patients it has to involve the rectum all the way around the wall of the rectum, the inflammation has to be, and then can extend any degree upward. And that inflammation could be mild. It could just be redness that we're seeing on like a colonoscopy, could be actually or frank ulcers that we're seeing. We'll talk more about this in the next few slides. So that's key. And it can't be outside the colon at all. It has to only be in the colon, the inflammation. And now, how does this differ from Crohn's disease? Anyone want to take a stab at that?
So there is like clinical, endoscopic, extraintestinal like manifestation for each of them. I think they can also serology as well.
Yep. So you hit on things. So extraintestinal manifestation. So yeah, we'll talk about that in a little too. And you can have that with both Crohn's and ulcerative colitis. So like joint problems, eye problems, skin problems. But one of the keys with Crohn's is you can have it anywhere in your GI tract, from the mouth to the anus. You could have isolated anal Crohn's, so you just have fistulas, these tracts, which we'll talk about in a little bit around the anus, or inflammation in the colon, the small intestine, the stomach, the esophagus, the mouth. It can involve anywhere in the whole GI tract. And unlike ulcerative colitis, it doesn't have to always involve the rectum, and it doesn't have to be circumferential. It could be very patchy, for example. So like when I'm seeing a patient in the IBD center, I'm saying, all right, so we say IBD is sort of this overarching term that includes Crohn's and ulcerative colitis. Ulcerative colitis has to involve the rectum circumferentially, and then any degree upward to involve the rest of the colon. And Crohn's, on the other hand, can involve anywhere in your GI tract. Doesn't have to be circumferential and sort of could be patchy in nature. So if you have something in your small intestine, by definition, it's then Crohn's. If you have it in your stomach, it's Crohn's, because again, it's outside of the colon. So that's sort of in a very like high level of what the differences are. So, highlighting this, as we mentioned, ulcerative colitis, only the colon. Crohn's can affect anywhere in your GI tract. And when we think about where Crohn's is, the majority of it is going to be, can you see my pointer moving, everyone? Sorry. Yeah. Is going to be in your ileum, so the very last part of your small intestine, or into the right colon, like where your cecum is. So this ileocolonic Crohn's disease. About 70% of people will have involvement in this area. Roughly 5-ish% will only have involvement further up in their small intestine. 5% will have involvement in their stomach or duodenum. 20% only in their colon alone. And that's for Crohn's. Ulcerative colitis, the distribution is different. Most people will have proctitis, so up to 60% will only have it in their rectum. up to, again, these are overlapping percentages because there's ranges, but up to 45% will have left-sided colitis. So this means the inflammation circumferentially extends all the way up to just the splenic flexure, no further than the splenic flexure, while pancolitis means more of the colon is involved than just the splenic flexure. So anything beyond that is called extensive colitis, and if the whole thing is involved, it's pancolitis. Any questions on that concept? So then, what are the endoscopic features that we see with Crohn's and ulcerative colitis? So what do you, so when we're doing colonoscopy, so the way we diagnose it is you have to see it. You're seeing with like a colonoscopy or an endoscopy, and you have to biopsy that and get histologic confirmation that that's what it is. But what are the kind of things we commonly would expect to see? And maybe this is a little bit general because I know we touched on this a little, but what do you usually see with Crohn's disease or ulcerative colitis when you're looking in?
Red mucosa, ulcers, swelling, bleeding.
Yep, exactly. Yeah, and I'll go to the next slide. So perfect, you hit a bunch of the highlights. So this is what your colon normally would look like. This is like a grainy old looking picture, but so this is, you see like this triangular appearance here. This is very characteristic on a colonoscopy of the transverse colon, has this triangulation appearance. But importantly, the wall of the colon looks kind of like a healthy pink color, and you see the blood vessels in the wall. And that's really key to see like these healthy red lines in the wall of the colon, which are our blood vessels that are present. When you see ulcerative colitis, so we touched on this, so you're going to have this circumferential inflammation. So you look in there, the whole wall should look red and inflamed. You can see here, there's no nice blood vessels in the wall like we saw in the colon before. There's some mucus or exudate on it. The whole thing is red and inflamed. And you're going to see continuous inflammation, edema and swelling, friability, which means when the scope touches it, the walls start bleeding of the colon, which shouldn't happen. You see erosions, which are essentially ulcers that don't have like that whitish base to them. If it has that white base to it of a mucosal break, then that's considered an ulcer. If it doesn't have that, it's so small, it just is like a little kind of red abrasion, that's called an erosion. It's like a smaller ulcer. The rectum has to be involved, and people will have these things called pseudo polyps, which are these little polyps that grow that have these whitish caps on them that are consequences of inflammation. And when you get healing that occurs, people grow these little inflammatory pseudo polyps that don't have a precancerous potential, but they're a marker of like old damage and inflammation. Crohn's, on the other hand, you see this cobblestoning. You'll see this on like board exams. Someone will say they'll have this cobblestoning appearance for Crohn's. And what that ultimately means is you can see like in this picture up here, you get this really nice, well, not nice, it's bad, but an ulcer, a large ulcer, another ulcer up here. And then you have this kind of like preserved mucosa between it, which almost looks like you have a cobblestone, like a stone-like road. And these sparing of mucosa between each of these large ulcers. And this is very characteristic for Crohn's. Ulcers, relatively spared mucosa, ulcers, spared mucosa, and it's this patchiness that you see. And that's that cobblestoning. You can see them described as serpiginous ulcers, like snake-like. You can see they're kind of like weaving throughout the colon. Segments can be uninvolved, so you could have it look like this, and then you go up a few more centimeters and it looks normal. And then a few more centimeters up, it looks abnormal again. This very patchy-like mucosa, mucosal inflammation. And then you can get complications from this, narrowings and fistulas, which we'll talk about in a second. It can be challenging. If you have really bad inflammation in your whole colon, it can be challenging to say, is it ulcerative colitis or Crohn's colitis? Because they can look very similar, and we can talk a little bit about that. But generally, for all intents and purposes, Crohn's is patchy, and you can have it throughout the GI tract. Ulcerative colitis, continuous, always from the rectum up. So what are the complications we worry about in Crohn's? So this gets to like why we tell people, all right, we're going to start treating you, and this kind of gets to the reason we treat people, to try to reduce some of these risks. What do we worry about? Two main things happening in Crohn's disease.
You get strictures and fistulas.
Strictures and fistulas, yeah, exactly. What is, I guess we'll start like, what is a fistula? How would you describe what that is?
Like an abnormal connection between two viscous compartments.
Yep, an abnormal connection. Yep, and it's going to be between two epithelialized surfaces of some type. So what ultimately happens, so it's interesting. So the inflammation in ulcerative colitis is mucosally based, very shallow and superficial. The inflammation in Crohn's is transmural. The whole wall is going to be involved. So what you can have happen is you can get these small little tracts that can form in the wall of the colon that can pierce through the serosa. And this little tract then from the inflammation, pierces the serosa, the lining of the bowel, and then can link to another epithelialized surface, another loop of bowel, the skin, someplace else. And that's that fistula tract that forms. So they can happen in almost anywhere. You can get it between pieces of bowel. You can get it from the bowel to the skin, which is an enterocutaneous fistula. You can get them to the bladder, so an usually from the ileum, ileovesicular fistula. You can get them around the rectum into the anal area, so it comes to the skin on the surface of the around the anus. That's a perianal fistula, or even rectovaginal fistulas, where they extends from the rectum into the to the vaginal canal. And if these fistula tracts, you can imagine if they leap from a piece of bowel and they start extending outward, but they don't link to another surface, another epithelialized surface, you can get a collection there. And that if it's infected, it's called an abscess. If it doesn't get infected though, and it's sort of just like this inflammatory collection, we call that a phlegmon. So then phlegmon is an uninfected kind of inflammatory collection that's a consequence of one of these fistulas that sort of didn't link to something else. They're pretty common. 20 to 40% of people get these in general. And the complications can develop, like these phlegmons or abscesses, in around 10 to 28% of people can ultimately get these. Any questions about fistulas? No? And we hit on this also before. The other main complication are strictures, which happen up to 25% of people will get these. So again, the consequence of the inflammation in the whole wall of the intestine, this transmural inflammation, is a deposition of often collagen, which results in a narrowing of this, which you can imagine makes things hard to pass. Like a pipe, things start backing up and you get this pre-stenotic dilation, this dilation up above the narrowing, which can cause obstructions and other kind of symptoms. And this gets to why it's important for treatment. So we care a lot about treating people, and we'll talk about treatments in a minute, to make them feel better. We want them to symptomatically get improved, but it's been shown that treatments, particularly when you can heal the intestinal tract so that it doesn't even look like that there's inflammation anymore, you decrease the chance of people developing these complications like abscesses, strictures, which has other kind of morbidities associated with it, like going to the hospital, needing prednisone, surgeries, all the things we sort of want to avoid. So we'll get to treatments also a little later. So Rachel, she's sitting in your office. She tells you that she heard IBD is an autoimmune disease and wants to know what's causing it. She explained that she was fine for the last 24 years. Suddenly, out of nowhere, this happened. She just wakes up with bloody bowel movements and sort of wants to know what's the cause of IBD. So so someone put into the chat, so environmental and genetic. So good. So let's start with her age. So this is interesting. So she says she's 24 and she gets IBD. What do you think about this age for being diagnosed with IBD? Is this like a expected kind of age or period, or is this unusual?
Expected.
Expected. What's the age that most people are diagnosed with IBD?
I believe there is two peaks.
Mm-hmm.
One of them around this age, like 20s, 30s, and the other one around 60s.
Yep, perfect, exactly. So the first peak is, as you mentioned, most people are about 15 to 35 years old. So 20s is sort of that prime age when people are being diagnosed with this condition. And then you mentioned that second peak, that we see a smaller peak in the 60s and 70s where people are again diagnosed with it. So yeah, she'll ask you, I was feeling well, I'm in my 20s, how did this happen? And this is sort of the time when this happens. And it often comes out of nowhere, where people will sometimes be fine, wake up sick with bloody diarrhea and stomach pain, or people can come with more of an insidious presentation where they're like, I've been sort of not feeling well with pains for a little bit of time. And there can be some of that kind of subtle presentation as well too. But great, yeah, so those are the main ages when people are diagnosed. And then we kind of get into what's causing this. And in the chat, someone had mentioned environmental and genetic. And yeah, and that's right. The bottom line is we don't know what causes this. And that's one of the hard things. it's important for people when we see them, because people will say it's an autoimmune disease, and it's not truly an autoimmune disease. So there's no autoantibodies that people are creating in IBD where you're attacking yourself. You're not attacking your own intestinal lining. And in fact, there are autoimmune enteritises and autoimmune colitises where you have measurable antibodies that people create against the colonocytes or the endothelial, the lining of the small intestine, and those are treated a bit differently. So in IBD, it's not that true autoimmune disease of attacking cells. And that's it's important where we kind of clarify that with people. But then what causes it? People hit on genetics and environment. And pretty much we're not 100% sure. It's some interplay between these two things. So we know there's a lot of genetic basis for the disease. There's been innumerable genes that have been diagnosed associated with getting IBD. When you look at population-based studies, you see an 8 to 10-fold increased risk of IBD among relatives with ulcerative colitis and Crohn's. The twin studies are very important, which and family studies, which really show that, like, if one kid in the family has it, there's a 26-fold increased risk that another child will have Crohn's disease in the family, a 9-fold increased risk for ulcerative colitis. But what's interesting is a lot of people will have the genes, but don't end up developing the disease. And also, when you think about that second peak we were talking about, there's not really many genetic conditions that come out when you're 75 years old, for example. So there's a little bit more to play here, which we still aren't sure of. And this gets to the environment. And people have been saying, what in the environment sort of turns on these genes or triggers these genes to become active and then results in this immune dysregulation? And no one is 100% sure what this is. There are interesting relationships that have been looked at. So if you, for example, have an appendectomy for appendicitis, you're more likely to develop Crohn's disease than if you didn't have an appendectomy for acute appendicitis. If you're smoking at the time of your diagnosis, in fact, smoking will make your Crohn's disease worse. It'll make the disease more severe, but it'll improve the severity of your ulcerative colitis. So people had looked into nicotine and nicotine enemas. Could this be doing something? Stress. Patients will often say stress exacerbates their symptoms or precipitated the flare, though the studies are sort of all over the place with that. And then things in diet, and this has been something that's been looked at as well. You see, for example, increasing prevalences in countries outside of Western countries in the world now. So you go to India and China, for example, and you start seeing marked increases in the prevalence of IBD. And people have been looking for things, what could be explaining that? So diet has been something people have been looking at. And people will say like a westernization of the diet, but that doesn't always necessarily mean people are blaming things like pizza on it. But what we see in certain countries is more use of emulsifiers and food preservatives in foods in some of these countries as well. And could that be at play? We know emulsifiers, which sort of make like your peanut butter mixed together so it doesn't look like water and kind of thicker stuff below it, really affects your mucosal lining of your small intestine, wipes it out. So it brings down, brings your mucosa in much greater contact with the environment. So could things like that be at play? Bottom line, we don't know. We don't know what the environmental factors are that are actually precipitating this dysregulation. But whatever it is, it does result in immune dysregulation that continues then for usually the rest of your life. And you have this abnormal interaction between the immune system of your gut and the normal microbiota and contents of the lumen. And it's this active inflammation, which draws in white blood cells, secretes a lot of cytokines. This immune response is what damages the mucosa, damages the lining and the intestinal cells, resulting in the ulcers, the inflammation, and therefore all the downstream symptoms that people are having. So we tell people, this isn't an autoimmune disease where your immune system is not purposely attacking your intestines. It's being overly activated through a combination of genetic and environmental factors that's resulting in this increased activity, which is damaging the lining of the GI tract. And our treatments, which are suppressing the immune system, bring this dysregulation into check in the gut and then allow for subsequent healing to occur. Any questions about all that or any thoughts? No? But yeah, that's an important part about the autoimmune thing, because we do have autoimmune conditions we do treat in the GI tract separate. So Rachel wants to know what symptoms you should look out for IBD. So, this is kind of straightforward, but what kind of symptoms do we think about or should we be looking for in people with Crohn's and ulcerative colitis? And why don't we start with Crohn's first? What do people usually kind of experience?
Diarrhea and abdominal pain, and like general symptoms, fatigue, fever, like low-grade fever sometimes, and the extra intestinal like manifestation as well.
Yep. So great. So diarrhea, you have fatigue, abdominal pain, and that's key for Crohn's. Abdominal pain and diarrhea are some of the two key features of Crohn's disease. Some people can have bleeding. What about for ulcerative colitis? What are the main features we think of for here?
Bloody stool.
Bloody stool, and bleeding is the key thing. You mentioned bloody stool. If someone who with ulcerative colitis is having diarrhea and it doesn't have blood in it, we very frequently think about other things that are going on, like C. diff or some other cause of it. It's been shown in multiple studies, this relationship between bleeding and diarrhea in ulcerative colitis, the bloodiness, is important for very much diagnostic of an ongoing flare for these things. So this is very, very general. Diarrhea, frequent bowel movements, bleeding, and you see, as I talk about abdominal pain, decreased appetite. And we want to think about other things too, our complications as well. So we mentioned this already on the left picture from inflammation. You get diarrhea, abdominal pain, weight loss, you have low-grade fevers, fatigue. Children who have it won't grow as well. And that's one of the keys sometimes that they have IBD, they fall off their growth curve. When people get strictures, you want to think, and when you see someone with Crohn's who's saying to you, I feel nauseous after I eat, I'm feeling bloated. These are things you want to think about where they could be having narrowings. Also, Borborygmi is a characteristic sign that you could hear for strictures. Does anyone know what Borborygmi is? It's when you can, it sounds, yeah. When you can hear your stomach growling like across the room. So people with Crohn's, particularly with strictures, will tell you, my stomach, it's so embarrassing. It growls so loud, everyone in the room can hear it. So when people describe that, that is associated sometimes with stricturing, where you have this high-pitched sound that's generated as food and debris move through these narrowed portions of the intestine. So this kind of audible borborygmi is sometimes a sign of stricturing as well. And then fistulas and abscesses. Well, fistula, you're going to get drainage. Like if you have it around the anal area or to the skin of the stomach, you'll actually see stool coming out to the skin surface. If someone has a fistula to their bladder, they'll very commonly report seeing maybe flecks of stool in their urine. When they urinate, they'll have air in the urine. So urine will come out, it'll stop as air comes out, then urine will come again, and that will be another classic description, as well as urinary tract infections that have multiple different bacterial types in it because it's dirty from stool. Are some of the characteristic. And then rectovaginal fistulas, people will come in and report that they have stool coming out of the vagina, which, and then that will be one of the key symptoms for that, or pain during intercourse would be another one of those classic symptoms. Abscess is just like an abscess anywhere in your body. Pain and fevers are the big things. Those are some of the main symptoms for Crohn's that we think about. And then for ulcerative colitis, we hit on this, bloody diarrhea. It's really important. So for proctitis, you're gonna have rectal bleeding. Urgency is a big thing. When your rectum is inflamed, people can't hold any stool in. As soon as they feel like they have a bowel movement, they're gonna have to run to the bathroom. So fecal urgency is a big thing. What's tenismus? Anyone know what tenismus is?
When you've just gone, but you feel like you need to keep going.
Yep, you feel like you can't go. So after you evacuate, you feel like you still have to go. And it's almost like people will describe it like a dry heaves of the bowel. So it's like when you're dry heaving, you're vomiting, nothing's there. When you have tenismus, you feel like you have to keep going. You're sitting on the toilet, nothing's coming out though. And that's from this rectal inflammation. And you could have people, and this is important too when you're dealing with ulcerative colitis flares, you want to ask people, how often are you sitting on the toilet and how often is stool coming out? People could sit on the toilet 15 times a day and not have stool. They just have this urge that's bringing them there, but they might classify it as a bowel movement. So you always want to tease that out, how many bowel movements you're having versus how many times you're actually going to the bathroom. And those are sort of some things to pick up on histories. When you have left-sided colitis, so as more and more of the colon gets involved, you'll actually start having true diarrhea, where you're actually having watery stool, though you could have that with proctitis. And then with really extensive or pancolitis, you can very rarely get fevers. So honestly, anyone that's having fevers in IBD is having a complication and needs to be urgently evaluated, whether it's Crohn's or ulcerative colitis. Fevers are not usually a normal sign for an IBD flare. That would be a marker of something being quite severe. So, all right, Rachel says, all right, so they put her on prednisone in the hospital. Her doctors talked to her about starting stronger medicines like infliximab, and she asked you, can you kind of discuss to me some of the treatments for IBD? So there's a whole bunch of different treatments that are out there, which all have different, parts of the immune system they go and treat, different mechanisms. But in a general sense, especially as an internist, it's a good idea to have ideas of sort of what are some of the main treatments that are out there, and sort of how do they work and how are they given. What are, I guess, can anyone think of, or start with like some of the main groupings of different types of medicines that are out there?
So there's oral, there's IV, and there's rectal.
Oral, IV, and rectal. Good.
So oral could be like mesalamine or prednisone.
Mm-hmm.
IV would be like infliximab, and then rectal would be like hydrocortisone maybe, or mesalamine.
Perfect. You hit on a lot of the big areas. So you mentioned 5 mesalamines, 5 ASAs. So these are taken. How are these taken? What are the 2 formulations or routes that these are given? Anyone know?
Like orally, rectally, there's like, I believe suppository, there's enemas, and there is like orally, which different in timing of release based on where do you wanna treat, is it of the colon or small intestine or up? Perfect.
Yep. So it can be given orally or rectally. The rectal formulations could be a suppository called Canasta, which you could see used. And when you give a suppository, that really just treats the rectum. So you could think of maybe 10 or 15 centimeters it'll affect. And then there's also enema versions of this. It's called like Ruwasa is the name brand for that. And the enemas kind of will get to most of the left side of the colon. Yeah, perfect. And you also hit on the fact that there's different formulations that open in different spots. So different medicines open based on pH in different areas of the bowel. So you can have some formulations that open in the colon or in the small intestine. And what disease are 5 ASAs used to treat? So what do we use mesalamines for? Which, does anyone know? They're used, if someone put something to the chat. Ulcerative colitis, so excellent. So they only work in ulcerative colitis. You should not use them in Crohn's disease. Some people will, we see use them, but there's no evidence that they work in Crohn's. So these mesalamines are immunosuppressive, but very superficially to the mucosal lining. So it doesn't have systemic effects on the body. So for ulcerative colitis, which is this mucosal-based disease, it works well to treat mild to moderate ulcerative colitis. Crohn's disease, multiple studies have shown no effects on healing the lining of the intestine. Prednisone and budesonide are 2 types of steroids, and steroids are good for short-term use to induce remission, help people that are feeling poorly very quickly, very broadly immunosuppressive, but have a lot of risks associated with them. Prednisone has a 60% increased relative risk of infection when you're taking it, for example. Long-term use, especially risks of cataracts, osteoporosis, weight gain, multiple other things that we worry about long-term. So it's used very short-term in IBD. The Amino Modulator. So this is like Azathioprine and 6-MP. Anyone know anything about these drugs? You can tell, like, how is it given, I guess, is the best way. How do you take those?
I think they're oral as well, and the idea is to try to bridge people off steroids so that they're steroid sparing.
Perfect. Yeah, oral. And they're given. And what can we use to treat with this? Because it ulcerative colitis, Crohn's, both. Do you know?
I think it's both.
Yep, you can use both. Yeah, and they're a pill that you take once a day. They're an older medicine, been around for IBD like for 50 years or so. People have been using them. They're roughly about 45% effective. So more or less, a little under half of people will respond to it. And you mentioned like getting people off steroids. So they're slow acting. So it takes about 2 to 3 months to fully work. So you need something to be able to help people feel better while you're waiting for these to work. And that's where things like steroids can come in. You can give someone prednisone for a period of time that you'll slowly taper it down, overlapping it with the 6-MP or azathioprine. And then as the steroids come down, you're hoping the effects of the 6-MP and azathioprine kick in and people start feeling better. We don't use them as much anymore, and that's because some of the risks associated with it. And does anyone know the main risks with azathioprine and 6-MP?
Myelosuppression.
Immunosuppression, yep, so there's some risk of infection. The main long-term risks we worry about is lymphoma. So they are associated with an increased risk of lymphoma. So in general, 2 people in 10,000 in the population will get lymphoma in general. On 6-MP azathioprine, that risk goes to 4 to 6 people in 10,000. So it doubles to triples your risk of lymphoma roughly being on those. And when you stop the medicine, that risk goes back down to normal. In men, it's associated with urogenital cancers. And then it's also associated with a lifetime increased risk of basal cell and squamous cell skin cancer. And even when you stop the medicines, that risk persists. So people have to still get yearly skin exams for life once you're on them. So we tend to favor the biologics over azathioprine 6-MP more now. The biologics, can anyone tell me kind of, I guess, what is a biologic medicine? How does that differ from like a regular medicine that we normally would take or give people for anything else, blood pressure, any other condition?
Like more specific to maybe like a protein or like anti-TNF or integrins or.
Perfect. So that's one great point. So they're very specific. So they're targeted, unlike azathioprine 6-MP, prednisone, even mesalamines that are much broader in their immune suppression, the way they act. Biologics are focusing on things like tumor necrosis factor or interleukins, very specific cytokines. They also are proteins, and this is important. All the biologic medicines are proteins, unlike just a standard regular chemical like another medication. And when you look at our treatments, this is kind of a little bit of an overview. So we talked about some of this. 5-ASAs can be used for ulcerative colitis. Steroids we talked about, you can give them to induce and help people feel better short term. Azathioprine 6-MP, we can use it in both conditions for maintenance, but it's slow acting, so we need time for it to work. Antibiotics, we don't use to treat IBD with. Methotrexate, we don't really use alone. It doesn't really work too well by itself. And then you have all the biologics. They tend to be more effective than azathioprine 6-MP. Depending upon the studies you're looking at, up to 60% of people will respond to these medicines. They all focus on different parts of the immune system, different cytokines. Infliximab, which is Remicade, and adalimumab, Humira, they inhibit tumor necrosis factor, as does certolizumab and golimumab. This is Cimzia and Simponi. Then you have things like Entyvio or vedolizumab, which inhibits an integrin, alpha-4 beta-6. Ustekinumab inhibits interleukins 12 and 23. So these are all sort of focusing on different parts of the immune system, all effective in, again, up to maybe 60-ish% of people. And most of these are available and are approved to treat both conditions. Some of them work quicker too. Infliximab, within a few days of treating someone, they'll feel better. But most of these, within a few weeks, people will start feeling better on the biologics. And then, not to go through too many of these, but then we have some newer medications that are small molecules. These are actual chemicals. You can see tofacitinib and ozanimod. These are pills that target also different parts of the immune system that are not biologics themselves. Generally, the biologics are safer. They have very small increased risks of infections and cancers, but those are lower than we see with azathioprine and 6-MP. So because of this increased effectiveness and slightly improved safety profile, we tend to use them, even though it can be scary seeming for patients who think, something you're injecting or infusing in a vein or blood vessel can seem more kind of scary and more dangerous. This gets to health maintenance. So Rachel wants to know about health maintenance. So what do we have to think of as an internist about health maintenance for people? And I just wanted to touch on this a little bit because it's important, especially, as a primary doctor and you're seeing a person with IBD, you want to be thinking about doing yearly exams, making sure they're up to date on their pneumococcal vaccines, their HPV, Tdap, and meningococcal vaccines. Anyone on a biologic cannot get a live vaccine. So this is important. You can't get nasal influenza. You can't get the live versions of the shingles vaccine or yellow fever. These are not allowed because there's a concern that the virus could get activated in the body. We want to make sure people are up to date on their and getting yearly cervical cancer exams, for their pap smears if they're on immunosuppressive therapy, annual skin exams because of the risk of skin cancer. And then for people with long-standing colitis for more than 8 years, if more than the left side of the colon is involved for ulcerative colitis or more than a third of the colon for Crohn's, people are going to need to get colonoscopies every 1 to 2 years for the rest of their life then to look for precancerous changes because of that risk of getting cancer. colon cancer with long-term IBD. And anyone with PSC, primary sclerosing cholangitis, you get yearly colonoscopies once you're diagnosed if you have IBD, because of that risk of colon cancer is so strong. For bone health, we at least check once vitamin D. Everyone's vitamin D deficient. Anyone who gets 3 months or more of steroids should have a bone density exam to make sure that they're not osteopenic or osteoporotic. And then we often will do routine blood work depending upon the type of medication that people are on. And then there's checklists that are available. So if you're interested and you're seeing a lot of people with IBD, you can go to the Cornerstone's website. So Cornerstone's is like this education society in IBD, and they have these very nice kind of printouts you can do that go over all of the health maintenance for IBD that might be needed. If anyone wanted to take a look at something like that, and it goes over specific things for each medicine. Any questions about that? I think someone maybe put something into the chat. I have one question regarding smoking and UC, as patients usually feel better symptoms control when they smoke. So we never encourage smoking for treatment of IBD because of the other health problems related to tobacco smoking. And this is only pertaining to tobacco smoke, not to like using marijuana. People who smoke cigarettes have a much more, as I mentioned earlier, aggressive course of their Crohn's disease. It worsens the disease. So it's really imperative for them to stop or reduce the amount of cigarettes they're smoking. Reduction of the number of cigarettes smoked in Crohn's disease helps improve the Crohn's disease course and the severity. For ulcerative colitis, it's been shown for people who were diagnosed with ulcerative colitis while they were smokers, they have improvement of the disease if they're smoking. And they'll feel better, and if they stop smoking, they'll feel worse. But we have a lot of medications to treat IBD, so we should not be using smoking, which has a lot of other health problems, to treat the IBD, and we should find something better, like one of our biologics or other medications to get them feeling better for smoking. For marijuana, this comes up a lot too. People will ask if that could affect their IBD. We don't know. There's not a lot of great studies on this. People will feel better when they smoke marijuana or when they take medicinal marijuana. Their GI symptoms will get better. Based upon the studies that have been done, it doesn't seem to worsen the inflammation of IBD, doesn't seem to improve it. So it's symptomatic only, no better or worsening of the inflammation as far as we can tell. We have someone in our IBD center, one of the doctors does prescribe medical marijuana to people to help with symptoms in certain situations. But I do always tell my patients, we don't know, we don't have enough data yet to say for sure it can't worsen your disease, because you always want to be cautious. With cigarette smoking, doesn't seem to make much intuitive sense that would worsen Crohn's, for example. So I think it's fine for people to use it if they need it for certain symptom controls, as long as we're sort of monitoring and seeing, what's happening with it. But I always do tell people we need a lot more data still in studies to just be sure that it's 100% not going to impact the severity of their disease. Someone had asked too, if the symptoms are well controlled, is it still common to get fistulas and abscesses? So it's important. So symptoms, and this is another thing always so important to tell people with IBD, is symptoms don't always correlate well with inflammation. And multiple studies have shown sometimes a discordance. So you'll see people who say, I feel great. You do their colonoscopy and they have significant inflammation in the GI tract, like ulcers that are present. And then there's other people who say, I'm having diarrhea all the time, and you look in and things look bad. So it could sort of go either way. There's a strong overlap between irritable bowel syndrome, functional diseases, and IBD. About 40% of people with IBD have irritable bowel syndrome, functional-like conditions as well. So we always want to be very objective to make sure that if people are feeling well, we're doing scopes to make sure that they actually are getting better on the medicine objectively. If you do heal the intestines, though, you should theoretically not be forming fistulas or abscesses or strictures. The presence or development of a fistula or something like that means the disease is still active and inflammation is still going on, and that would necessitate kind of a reevaluation to make sure that sort of the disease is nothing is kind of still going on objectively otherwise. But if someone has a new fistula and they're on treatment, we rethink about the treatment and start saying, okay, we need to find a better way to get this under control because clearly something's going on. Someone else asked, does treatment lower the colon cancer risk? So I remember like on my GI boards, there was a question that said, someone had pan-ulcerative colitis for 30 years. What's their risk of colon cancer? And the answer on that question was 18%, which is super high. And that's based on old literature and isn't really kind of accurate anymore to say what we see as far as colon cancer risks. So we have better scopes, being able to pick up small polyps better and lesions. We have better medications that are more successful at treating people now. So we you probably have just a very slightly increased risk of colon cancer having IBD compared to the general population. But inflammation causes damage to the intestinal lining, which predisposes to dysplasia development that can progress to cancer. So treatment, suppressing inflammation, should theoretically then decrease your chance of getting colon cancers, which is sort of sometimes what we're seeing in this in the studies that are showing somewhat lower rates now than we previously had seen. So we try to treat successfully to kind of decrease that chance of cancer in IBD from developing. I think I only have like 1 or 2 more minutes. So I wanted to just, this was just on the end in case we had time, but I wanted to just go over when you see someone in the ER, because this comes up especially as a resident a lot, where you see people with IBD in the ER and just some of the important things to cover. And instead of just going through this case quickly, I just wanted to kind of very briefly touch on this. Someone just messaged, when a patient with known IBD, compliant with meds, including steroids, presents to the ED with abdominal pain and diarrhea, what do you recommend the approach is? As a possible infection versus flare. So perfect. So that's exactly what I wanted to hit on in the last couple of minutes. So when you think about severity of disease, we use this thing called the Truelove and Witts Severity Index, which was published a while ago by Truelove and Witts in the 50s, and we still use it now to classify colitis flares. And really, this is for ulcerative colitis. And it just kind of goes over the number of bowel movements that you have to have each day to be considered mild, severe, or fulminant. Essentially, if you have 6 or more bowel movements per day, with frequent blood, it's considered to be severe. You could have other markers too, like your inflammatory blood count, inflammatory markers being up, or the blood counts being low. But really, that's sort of the main cutoff. So anyone you're seeing with IBD in the ER, you have to think about the test you're going to order. So everybody, you should largely be getting a CBC, I get a CMP, so a comprehensive metabolic panel, a CRP, and an ESR. So you're seeing what their blood counts are, which are important. Are they anemic? Do they have a white blood cell count? Is their kidney function okay? And what are their inflammatory markers? So you want to sort of get a sense of how they are, especially if they're having a lot of diarrhea. We would want to check a lot of times beta HCG to see if someone's pregnant, if it's relevant, because a lot of times people are getting imaging. But those are the basic labs everybody should get. Anybody who's got any abdominal discomfort, you should check an abdominal X-ray. And this is because dilated colon and dilated small bowels both significantly have been shown to increase your chance of needing a colectomy during or surgery during your hospitalization. So that's really kind of key. So anyone with abdominal discomfort, an X-ray. If it's really bad abdominal pain, you're going to get a CT scan. Everybody should get stool studies. So it should be C. diff, and we don't check culture as much anymore, C. diff and GI PCR. So this is when you're saying like coming in with the flare. So yeah, we're going to check blood work, stool studies, imaging of the abdomen if we're at all worried, and then we're going to see if it's an infection, we can treat the infection. If that comes up negative, then we have to be concerned that they're actually having a flare of their IBD. And very frequently what we'll end up doing in the hospital is a colonoscopy to get an objective assessment of what's going on in the colon. You also want to check for anybody that's getting admitted who might get therapies like a biologic, for example, in the hospital. You're going to want to check their quantiferon and hepatitis B serologies. Quantiferons take a day or so to come back, so it's important to get these right away when someone comes in, especially before steroids, which can make the test a lot of times come back indeterminate. And then this kind of sets it up so that we can give biologics, particularly if the person's flare isn't doing well and they're kind of getting worse. And that's those are really important. And very frequently for people that have bad ulcerative colitis flares coming in, or Crohn's flares, we get surgery on board early, just to work in a collaborative way with us. You tell the patient, we're not going to be doing surgery. Definitively, we just want to have them on board. They're part of our team, just in case things get worse. So again, full set of labs, stool studies, abdominal imaging, and then from all of that, you start getting a handle on, is it an infection or could it be IBD, especially if the inflammatory markers are up. And then you want to start thinking about other medications and things. So 5-mesalamines can sometimes cause paradoxical diarrhea. So you can think, could it be causing the medicine cause diarrhea in this person? You want to avoid narcotics and anticholinergics. If they're having a lot of diarrhea, make sure their electrolytes are repleted and they're getting fluid. You want to feed your patient. There's no reason you can't feed people. It's not going to make their inflammation worse. It can just cause symptoms, but it won't cause inflammation to worsen at all. And there's no role for prophylactic antibiotics in people with IBD. If they're febrile, they have peritoneal signs, they have C. diff, then you're going to use an antibiotic to treat them because you have an infection that you're treating. But we don't use it for just Crohn's disease or ulcerative colitis in itself. Multiple studies have shown no benefit with that. And then DVT prophylaxis is important. Even if someone's bleeding with 10 episodes of bloody diarrhea a day, they need DVT prophylaxis. The rates of DVTs are very high in people with IBD because they have a pro-inflammatory state. So unless someone's hemorrhaging, like a real true GI bleed, they should almost all for flares be on DVT prophylaxis. Even again, like 10 bloody bowel movements a day, they still should get the heparin or whatever you're giving equivalent to that. What is a realistic goal for symptom control when treating someone and titrating meds? So if this, I don't know if it's from Jonathan in the chat, I don't know if this is in the hospital. In the hospital, we're trying to get their symptoms under control pretty quickly. Again, usually it'll involve, I'll show you on the next thing. Usually it'll involve giving IV steroids to treat people to get them under control, their disease under control. People respond to IV steroids better than oral steroids, so we use it in the hospital. And usually we give methylprednisolone, solumedrol, up to 60 milligrams a day, either 60 milligrams once a day or 20 milligrams 3 times a day. You don't want to do this until you've ruled out infections though. So if someone has C. diff, you don't want to start steroids until you know that they have, if they don't have C. diff, you wait till it comes back, then you start the steroids. If they have C. diff, you want to start treatment for the C. diff first, and then sometimes in the next day or two, depending on how they improve on the C. diff treatment, we'll start the steroids once they're on therapy, if they're not improving enough. But that's really one of the mainstays of our treatments in the hospital. And then we also want to monitor people over time on their steroids, looking at how often they're having bowel movements, they're bleeding. Often we'll have people fill out a diary each day just to keep track of all of this. And we're trying to trend their ESR and CRP each day of the hospitalization to be sure that they're continuing to improve otherwise objectively. And other treatments, so you'd call the gastroenterology service too, to have them on board, and we usually will use infliximab. Remicade ends up being our primary salvage treatment in the hospital. The other biologics and medicines are not approved for inpatient use, and they don't work quick enough. Even things like Stelara, ustekinumab, for example, takes a few weeks to really start working. So giving it to someone in the hospital tends to not make a difference in their course because it's going to take a few weeks for them to get better anyway. So really it involves IV steroids and infliximab as our Remicade as our 2 main in-person treatments. In the chat, it came up, what pain meds would you suggest? Yeah, so NSAIDs we want to try to avoid because there's this theoretical risk that it could precipitate flares. Opioids can be used, so we do use it in people with IBD who have pain. If people are requiring a lot of pain medicine, it is concerning in IBD. So in my IBD practice, I never prescribe opiates as an outpatient. If someone needs pain medication, that means they need to be in the hospital because you shouldn't need opiates for the IBD-related pain as an outpatient. It shouldn't be that bad. If it is, they need to be evaluated urgently for complications and other things in the severity of the flare. In the hospital, we do use opiates like on our IBD service. You want to use them sparingly if you can, again, thinking about how it can affect the bowel. Some people do need them, but when people are requiring a lot of opiates and pain medicine, this is a marker of very severe disease. And again, this becomes in these conversations about how the medical therapy is being effective enough for the IBD. Do we need to be thinking about surgery early as well, or these other things? But again, as needed, opiates are okay to use if it is needed. Just something we want to be thinking about in someone with this bowel condition, about standing opiates, not monitoring them appropriately for why they're actually needing it, and are things changing, like is their colon dilating or other things in the bowel. Surgery, again, you would consider this if someone's having massive amounts of hemorrhage, if someone's developing toxic megacolon in the hospital, or in the outpatient setting if someone has colorectal cancer or a lot of dysplasia, precancerous changes, or just isn't getting better from their medications. And the ultimate goal is, Dr. David Sacker, who's one of the chiefs of GI, it's not, we always say this, you try to save lives, not colons. People can pass away from colitis, especially from ulcerative colitis flares. So we always want to be kind of cognizant of that, we always wanted to get the surgeons on board early in case the medical therapies aren't working. I know I went through the hospital stuff kind of quick, but I wanted to at least hit on it before we ran out of time. Has there been someone mentioned, has there been association between vaping and alleviating UC symptoms similar to cigarettes? I'm not sure about vaping data. It's a really good question. Haven't seen anything directly in vaping though. Someone might have looked at it, but I don't know. Good question. If there isn't anything, that's a good study. So who wrote that in there? Because it's something that a lot of people are doing. But yeah, that's really the end of the talk. So I know we went quick at the end, but I hope it was at least helpful kind of going over some of the basics of IBD and just sort of the general concepts of how we think about it and explain it to people.
Thank you so much, Dr. Hirten. I think we could keep you here all